Okay, so yesterday we talked about heart rhythms and arrhythmias. We talked about bradycardia. There's only two ways to get bradycardia, either the sinus node dysfunctions, sick sinus syndrome. It just reduces the automaticity, the rhythmic nature of it. It just slows down. And because it's the pacemaker cell of the heart rate slows down as well. The other way is via what? AV node dysfunction, and there are 4 different ways to have AV node dysfunction. Type 1, PR interval is just lengthened. The AV node holds on to that charge a little bit longer before it sends it off to the ventricles. So the R starts the ventricular depolarization. So we look at the start of the P. When did the SA node first fire? And how long does it take to get to the ventricles? The longer that takes, we have an AV node block. Type 2nd degree, type 1, longer drop. It's the Winky-Bach one. That PR interval gets longer and longer. Then you drop a QRS. You have a P wave, but no QRS complex. And then the cycle starts over again. Type 2, 2nd degree AV block type 2. PR interval is okay, but you get random dropped QRSs. If you get a random dropped QRS, the charge got stuck in the AV node and it didn't get out. So eventually something had to happen to the ventricles to make it squeeze. So that's type 2, 2nd degree AV block type 2. Type 3, there's no communication at all between the top and the bottom of the heart. The top is just going to be at its normal, so your P waves will be at a rate of 100, but your ventricular rate, looking at the QRS complexes, is going to be a lot slower. Okay? Then we went over heart failure. Make sure you understand the differences between left and right. Why do they get those symptoms? Where is the backup happening? Remember your anatomy. If the left ventricle can't pump it out, left atrium, pulmonary veins, the lungs. Okay? Right-sided heart failure, either it's left-sided is the cause, or they're going to have some intraparenchymal issues with the lung itself causing the congestion. So your etiologies for the right and left are going to be a little bit different. We're going to go through a little bit more of those etiologies today as we start filling in some diseases and some issues. Now we're going to move on to cardiomyopathies. These are abnormal heart chamber sizes. There's different ways it can happen, but this is usually the end result of long-standing high blood pressure, heart failure, certain toxic metabolites. Alcoholism is toxic to the heart, causes changes, and we'll go through those changes and what happens to the heart. So the heart is going to remodel as it fails. There are 3 ways it's going to do it. It's going to dilate, it's going to get thicker, or we're going to talk about a restrictive heart disease. We talked about restrictive lung diseases a little bit in physio. We talked about pulm. Remember I said with restrictive diseases, especially with the pulmonary system, think about you're wearing a straitjacket and you can't relax. You can't expand your lungs to get all the air in. With a restrictive cardiomyopathy, the heart can't relax. So if it can't relax, it can't fill. And you'll see the changes that happen later on. Hypertrophy, remember from lecture 1, is an adaptive response. You have to figure out, is this hypertrophy that's going on with this person, is it physiological? Highly trained athletes. Anyone here do long distance running? A lot. I'm scared to volunteer. Okay, so people who do a lot of long distance running, marathons, what's their normal heart rate? Really, really low. Why is it really low? Because the heart got very efficient. The stroke volume is higher in those patients. Because the heart is very efficient, it can squeeze better from all that training. Having the heart rate low, remember cardiac output still needs to be 5. 5 liters per minute, whether you're an athlete or not. 5 liters per minute is what we all need. So in athletes, if their resting heart rate is 40, then you know their stroke volume is going to be higher. So they're more efficient. Pathologic causes of cardiomyopathies. Hemodynamic overload, that's your long-standing high blood pressure. Myocardial injury, you had a heart attack. Some of that muscle tissue is dead now. It's not going to squeeze properly. You're going to get changes in the way the heart squeezes, and it's going to remodel itself and change shape. Valvular insufficiency, we're going to talk about valves today. We're going to listen to a lot of sounds and how the heart sounds and why it makes that sound. In PD, you guys will practice heart sounds in a couple weeks. I think cardio is the last section, or maybe it's the second one. So after you guys do your ENT optho for PD, you'll go into cardiac and vascular will be the next section. Why exercise is considered physiological when the heart gets stronger? It's because heart rate variability is the biggest reason. There's no definite reason why, but heart rate variability, which means that for 23 hours of the day, your heart rate's pretty relaxed, but for that 1 hour that you're exercising, your heart rate goes up and down. That variability is good for the heart, but obviously not all the time. So these are the different types of cardiomyopathies. Here's our normal heart. You can see the way the valves, the thickness of the walls are. Obviously, the left ventricle is going to be bigger than the right ventricle. Now let's talk about, here is your cardiac dilation, a dilated cardiomyopathy. In this case, the muscle myocyte length is greater than the myocyte width. So the walls get thin. Look at the walls in this one compared to the one above. Very, very thin walled, very, very thick walled at the top. Look at the size of the chamber of the left ventricle. It's only that size. Look at the size of that chamber in the left ventricle. Really, really big. This is a dilated cardiomyopathy. Thin walls, very big chamber. Okay. Reasons for this: extensive fibrosis, myocyte death, and some advanced cardiac dysfunction. Pathologic hypertrophy due to chronic hypertension, aortic valve stenosis. Aortic stenosis will cause hypertrophy of that left ventricle. Myocyte length is increased, but it's less than the myocyte width. So we get thickened now. Look at the size of the walls in that left ventricle. The walls got very, very thick. The septum, this is your IVS, got very thick as well. So the chamber got thicker, but the chamber size got smaller. Everyone see the chamber size got smaller? On the right side, this is physiologic hypertrophy. The chamber size and the thickness of the walls are in proportion to each other. The heart will still have the right proportions in a physiologic hypertrophy due to exercise. So that chamber size and the thickness of the walls are still in proportion, so the heart will still function normally. And this is physiologic, which means it's a normal response, obviously mainly to exercise. So that's remodeling. So let's talk about dilated cardiomyopathies first. This is the most common type of cardiomyopathies. Causes about 10,000 deaths and 46,000 hospitalizations a year. Idiopathic, what does idiopathic mean? Unknown, we don't know why. So idiopathic dilated cardiomyopathy, DCM, dilated cardiomyopathy, many cardiac transplants. Secondary results from injury to those myocytes. Characteristics of a dilated cardiomyopathy: biventricular, usually both chambers are going to be affected, both ventricles. Dilation, chamber size gets big. Impaired contraction, all those myocytes are now lengthened. Remember what we talked about? Go way back to skeletal physiology. We talked about how our muscles are lined up normally in a way to allow constant cross-bridge connection. But if we lengthen that out, you have less cross bridges available for binding because we stretch the sarcomere out too much. Therefore, our contraction is compromised now. We stretched it out too much. Eventually, they're going to get congestive heart failure because the heart is not going to squeeze properly. If the heart can't squeeze, it's a pump. That's all the heart is. It's just a pump. If the pump is not working, you get no flow. Can occur in the absence of hypertension, CAD, and valvular disease. So as far as, oh, this patient has a dilated cardiomyopathy, don't just assume they're going to have CAD hypertension. It could be other reasons to cause that dilated cardiomyopathy. Alcohol, like I said before, are toxic to cardiac muscle cells. So chronic alcoholics, you have to watch out for their heart. Also, maybe a genetic component to these DCMs as well. So what's going on? Heart muscle dilates, becomes very thin. Contractile elements don't align. Actin and myosin, they're not lined up properly anymore because the sarcomere got lengthened. So we can't contract very well. So we may get some systolic impairment. That's the squeeze. We can't squeeze because we have less muscle force generation. They may be asymptomatic, not having any signs or symptoms of heart failure. And again, they may or may not develop overt heart failure later on. Sudden death may occur at any time, and they can either have atrial or ventricular arrhythmias. So here is a picture of what a dilated cardiomyopathy looks like. And let me try and get it into the picture. Okay. Here is the septum. Look at the ventricular free wall, how thin that is. Okay, very, very thin wall. Yes?
Can this lead to a dissection?
A dissection? What kind of dissection?
Like a septum dissection? Like, can it stretch so thin that it just...
I don't know. I mean, I think it could rupture. It's not very common that's going to happen, though. Anyone know what those wires are? Not a pacemaker. What's the other one? Defibrillator. These are shock coils. These little, the silver things on the end. Those are the shock coils. So remember, if you're doing defibrillator outside, external defibrillators, you have one pad and one pad on the chest. Now, they have it built into the heart. So they have one signal up here, another signal down there, and it sends the charge, and it zaps the heart to go back into a normal rhythm. Because the incidence of sudden cardiac death due to ventricular arrhythmias is elevated when you have a DCM, one of the things you do is you give someone a defibrillator, which they can be anywhere in the world, and if their heart goes into a bad rhythm, it's going to shock them, and they'll wake up again, and they'll be okay. But if they don't have the defibrillator and they're randomly anywhere in the world, and their heart goes into a bad rhythm, they better get an external defibrillator or they're going to die. So this is a protection for the patient to prevent sudden cardiac death. So that's what the defibrillators are for. Yes?
So you diagnose arrhythmias, and then do you do like a scan of anything to determine that they have
So you'll do an echo.
an echo?
So one of the things you figure out as you get into CMS is the plan. What am I going to do? One of the things to start figuring out as you go through different disease systems, what are the most common presenting complaints? For cardiac, they're going to show up either with chest pain, palpitations, shortness of breath, or syncope. Those are the big four things they're going to show up with. All the diseases are going to fall into those categories. So just start thinking about, okay, what am I going to do for this patient? They're coming in with chest pain. I'm going to get an EKG to see if there's any ischemia. I'm going to get an echocardiogram, which will visualize the size of the heart, the chamber size, the function of the heart, and that will tell me if this heart's under any stress. So between those two things right there, I'll look, do I have any arrhythmias on EKG? Do I have any structural problems with the heart? When you think of the cardiovascular system, think of it as a house, not a house, but is it a plumbing problem, meaning vessels pump, or is it an electrical problem? The electrical activity of the heart causing these issues to happen. So think about it, is this a pump problem, or is it electrical? And start thinking about that as you go through these cardiac diseases. These are pump problems that can cause electrical issues, but it's a pump problem. This is not electrical. The arrhythmias were electrical issues. Atrial fibrillation is an electrical issue with the heart. So this is dilated cardiomyopathy. The next one, hypertrophic obstructive cardiomyopathy, also known as HOCM. Okay, with HOCM, what happens here is we have a very thick interventricular septum. So the IVS becomes very thick. And you can see that right here. Let me change the colors. Okay, so the IVS gets thickened than it normally will be. When this happens, when the heart squeezes, this septum goes into the left ventricle. And when it does that, look at the outflow tract. Here's the aorta, right? Let me change the color. The aorta is right here. So the blood has to pull in here and it has to come out that way. But the septum gets in the way. How much blood do you think can get out when the septum blocks the outflow tract? Not much. So blood flow goes down because we have a blockage. This HOCM obstructs the outflow tract, causing issues, and we'll get to that in a second. So keep that in mind. The septum becomes thickened. This is a hypertrophic cardiomyopathy. The interventricular septum becomes hypertrophic, whatever the word is. It gets thickened. And when it gets thickened, as the heart squeezes, that septum bows into the outflow tract, causing issues. So we'll see what happens in a minute. Genetic issues usually is what's causing these HOCMs to happen. This is the thing that causes death in these young athletes. You see them passed out on the floor. This is what it is, hypertrophic cardiomyopathy. So what happens is as your heart rate goes up, your heart is squeezing more vigorously and harder so that septum gets in the way more aggressively when you're at high heart rates. And now you don't have the blood flow leaving the heart because you have a blockage there. And what happens? They pass out because there's no blood to the brain, lack of blood. So that's what goes on with these patients, and obviously they get ischemia to the heart as well, causing these heart rhythms to happen. When you have this HOCM, because we said it's a genetic problem, they have an issue with the sarcomere, the way that they look. When you do a histology of these patients' cardiac muscles, you're going to see that it's arranged as these whorls pattern. Okay, all disarray, so think of whorls when it comes to HOCM. If you did a histology of these patients in the cardiac muscle tissue, it would appear as whorls, not straight sarcomeres like we normally like to see, like in the skeletal muscle. So that's HOCM. Now, characteristics of HOCM: inappropriate left ventricular response, hyperdynamic left ventricular contractility. Again, the septum is thickened, it's not going to squeeze properly. Stiff, non-compliant left ventricle. Strenuous activity makes it worse. Okay, signs and symptoms of a HOCM will be dyspnea and angina, just chest pain. Wait a minute, did I? Okay, it's in the valves. So HOCM, we are going to come back to HOCM when we talk about aortic stenosis. So keep this in mind when we talk about aortic stenosis. We're going to come back to this because when you guys do your cardiac exam, you all go to Erb's point, right? Valve 1, 2, Erb's point, 3, and 4. Erb's point is only used if you hear a heart murmur. And we're going to talk about that murmur in a second with aortic stenosis because HOCM and aortic stenosis sound the same. What do you have the patient do when you listen to Erb's point? Bear down, right? That's going to change the hemodynamic response, and we're going to see how this murmur changes. The restrictive cardiomyopathy is the rarest form. Stiff, fibrotic ventricle. Because it's stiff and fibrotic, whenever you see these words, think about filling problems. So ventricle with impaired diastolic filling. Keep these things in mind. Stiff fibrosis, the heart is not going to squeeze as well, but it's also not going to relax. The heart has to relax to get blood inside of it. If the heart can't relax, it can't open up to allow the appropriate volume to come in. Myocardium will become fibrosed, rigid, non-compliant, lead to heart failure. Only 10% of these patients with a restrictive cardiomyopathy will survive more than 10 years. Okay. Restrictive cardiomyopathy characterized by restrictive filling, reduced diastolic volume on the left or right side of the heart. However, the problem with restrictive is a filling problem. Is it a squeezing problem? Squeezing is okay. It's just a filling issue. So in this case, normal systolic function remains because it's a filling problem. It's not a squeezing problem. It's filling. So usually near normal systolic function. Usually if someone has a restrictive cardiomyopathy, even when we start talking about pulmonary pathophys next week, anything that you hear restrictive, it's going to be an infiltrative disease. Sarcoidosis, amyloidosis, hemochromatosis. You don't know what they are yet. You will as we go through certain things. Just know that these are infiltrative diseases. They deposit stuff into the tissue. And when it does that, just like we talked about with lupus, anytime things are deposited into tissues, they don't work well. So in this case, we have these infiltrative diseases on the heart causing filling problems, and they're not going to fill well. Signs and symptoms. Exercise intolerance. They don't have the filling. They're not going to have enough blood. The stroke volume, or the ejection fraction will be normal, but the stroke volume is going to be really reduced. Not much there. Same thing with restrictive lung diseases. It's a filling problem. It's not a breathing problem. We talk about the restrictive lung diseases. They can't fill the lungs well, but they can still move air. Restrictive cardiomyopathies, they can't fill with blood well, but they can still squeeze good. So that's where the problem comes in. Dyspnea, weakness, again, lack of blood, moving around causes weakness. So here's a good little slide talking about the different types, and you can see the different wall thicknesses, chamber sizes. Makes you understand the differences between the three: dilated, hypertrophic, and restrictive types of cardiomyopathies. Okay, that's where we were supposed to finish yesterday, or Wednesday, so we'll keep going. Okay, moving on to our valvular heart diseases. There are only 4 that we're going to talk about in this class. In cardio, you will talk about the tricuspid and the pulmonic valve. However, the majority of the time, if they have a tricuspid valve infection or a valve problem on the tricuspid side, it's usually due to endocarditis, some sort of infection, IV drug use, something going on that vegetation attached to that valve causing issues. We're only going to talk about the aortic and the mitral as they have the most consequences with the body, but the same things will happen with the tricuspid and the pulmonic valve, and you'll learn more about those in specific parts in the classes. So with valvular heart disease, it's either going to be a stenotic or a narrow opening, or it's going to be a leaky or regurgitant valve. Okay, I already talked about that already. So when you are listening to your heart sounds, whether it's a murmur, it's a bruit, they're the same things. It's turbulent flow of blood across a valve. And what's happening is that valve is vibrating from the blood flow going across it, and that causes you to hear a murmur. So if you turn on a faucet and it has that little screen on the front of it, it's going to make a sound as the water comes out, shh, because it's going through a screen to filter it. If you go to the water fountain in between the bathrooms, When you put your water in, it has that laminar flow where it looks like one straight tube coming down. That doesn't make a sound until it hits your water bottle, but the water coming out of it is nice and clean. When you have nice, great valves, you don't hear any murmurs or bruits in the carotids when you don't have any blockages in the area. A blockage, turbulent flow makes a sound, and that's all you're hearing with murmurs. Turbulent flow across the valves. Even the heart sounds, the S1 and S2 is just closure of the valves. And they make a snapping noise, and that's what you're listening for. S1 and S2 is the snapping closure of the valves. So this is the important part. Being able to differentiate a systolic versus a diastolic murmur. That's the first goal when you are listening through murmurs. Is this a systolic murmur or is it a diastolic murmur? Systolic murmur, we know that during systole, the mitral valve is closed and the aortic valve is opened. So therefore, the murmur is either due to aortic stenosis or mitral regurg, because that's what's going on with the valves at that time during systole. During diastole, it's the opposite. The mitral valve is open, the aortic valve is closed. Therefore, any diastolic murmur, aortic regurg, or mitral stenosis. Stenosis of the valves happens slowly. They don't just wake up tomorrow and have aortic stenosis. It's a gradual thing that happens. Regurgitation can be either acute or chronic. You can have an acute mitral regurg or aortic regurg, or you can have a chronic version. What do you think you're going to have to find out from your patients? Some history. Figure out how long have they had these problems? Were they sick recently? Did they have a heart attack recently? A bunch of different questions you have to start asking to figure out, is this an acute situation or is this chronic? So what do I mean by, oops. Okay. Okay, so here's your S1 and S2. Okay? If you hear things in between, this is a systolic murmur. Oops. This is systolic. If the murmur happens outside, this is your diastolic. Okay? So when you start listening to hearts again in PD, I'm going to play some videos for the different heart sounds. We're going to close our eyes because one sense goes away, the other ones get better. And listen for the S1, S2. They're going to play normal heart sounds first and then the abnormal ones. And you'll hear where the sound comes in. Think about it. If it's happening between S1, S2, it's a systolic murmur. If you hear it outside S2 before S1 happens, it's a diastolic murmur. Okay? So, aortic stenosis is the first one we're going to do. Aortic stenosis is usually the first one that you're going to hear. It's a very, very easy murmur spot. Usually, again, because it's stenosis, it's going to take a very long time to develop. There are three cardinal symptoms of aortic stenosis: chest pain, syncope, and heart failure. They are in order because once you start getting these symptoms, your life expectancy changes. If you have aortic stenosis and you start getting chest pain, expectancy of life is 5 years. Again, untreated. A lot of the things we talk about, again, is untreated diseases. You can treat aortic stenosis. One of them is just a valve replacement, but there's other things you can do. If you develop syncope with aortic stenosis, life expectancy drops to 3 years. If you have aortic stenosis and you develop heart failure due to the aortic stenosis, untreated, life expectancy is down to 2 years. So you have to know these symptoms for aortic stenosis. Physical exam findings. When you palpate, the carotid upstroke reveals with aortic stenosis pulsus parvus, which is a decreased upstroke. It's not going to feel as strong as a normal heart would. And it's going to be pulsus tardus, which is late. It's going to feel later than it should. Okay? We're going to have a laterally displaced and sustained apical impulse. So what would cause your apical impulse to be displaced? We talked about it on Wednesday. Hypertrophy. Okay? Keep that in mind. It's going to come back. Aortic stenosis is a mid-systolic murmur, loudest at the base of the heart, and often with radiation to the sternal notch and neck. Okay? And we'll play sounds for this in a second. Depending on the cause of the aortic stenosis, you may have a crisp, high-pitched aortic systolic click just after S1, not very common. You may have a soft or absent S2 as the disease progresses. So, I said, if this is your normal aortic valve area, and aortic valve closing is at S1 or S2? S2. S1 is the mitral, S2 is the aortic valve closing. So if this is your normal aortic valve area, when the valve closes, it's going to make a snap. And that's your S1. This is a normal width of an aortic valve. I'm just making it up for demonstration purposes. If I was going to make a stenotic valve now, what do my hands have to do? Cut closer together. So now, you hear how soft that is? S2. Now, if they have aortic stenosis, because we're closer together, a quieter sound. And that's why S2 drops, because you're already stenotic. You're not all the way expanded, you're halfway, and it makes a quieter sound. That's why you have a soft or potentially absent S2 as this aortic stenosis gets worse and worse and worse. You can also have an S4 present as well. What is S4? Atrial kick. Atrial kick is S4. Blood hitting the ventricle is S3. So this is where age matters. You guys are going to get a lot of vignettes going forward now on your exams. Again, we're getting you ready for the PANCE. So we're going to have a lot more vignettes. And they're all going to start the same way. Age, sex, presents to so-and-so for this reason. A 45-year-old male comes for this reason. A 23-year-old female comes for this reason. The age that we give you does matter for the question. Not all of them, but in this case it does. So what are some causes of aortic stenosis? Congenital. They're born with it. So obviously, I would say an 18-year-old, a 20-year-old would have these symptoms because they're born with it. The majority of them are going to have a bicuspid aortic valve. How many cusps does an aortic valve normally have? 3. It's a tricuspid. Aortic valve has 3, but in some people they have 2. So it's a 2 valve. It's not normally 3. Now it's down to 2. Obviously, your aortic valve area is going to be decreased because you only have 2 leaflets instead of 3. You get abnormal flow, fibrosis, calcification. A lot of these stenotic valves are calcified. Whenever you see calcification, it's old. Okay? Old stuff. So it takes a while. Symptoms will develop before age 30. So if I say a patient with a 25-year-old male has heart sound indicative of aortic stenosis. Your reasonings better be bicuspid, a congenital problem because of the age of the patient. If they had rheumatic fever as a child, isn't that one of the questions you ask everyone on your history? Any childhood illnesses, history of rheumatic fever as a child? The reason you ask about rheumatic fever is because rheumatic fever can affect your valves. So it causes tissue inflammation, which causes adhesion and fusing of the commissures. So those little leaflets start to fuse together. If they're fusing together, what's happening to your aortic valve area? Decreasing, causing stenosis. In this case, symptoms develop between ages 30 and 70. And the valve may also have some regurgitant flow as well. The last one is degenerative. This is mainly due to calcium at the bases of the leaflets. So they don't bend as well anymore. They got very calcified. The leaflet tips are okay, but in a degenerative aortic stenosis, mostly after age 70. Because again, this is a true aortic stenosis due to calcification of the valves. It takes a very, very, very long time for that to happen. So over 70, degenerative. Middle-aged, probably rheumatic. If they're young, congenital due to a bicuspid aortic valve. An echocardiogram will tell you they have a bicuspid valve. This is something that you're not going to know. If someone comes in and they've never had a murmur and now they have aortic stenosis, you're going to get an echocardiogram regardless, and that will tell you exactly what's going on with the valves. So this is a big one to know as far as ages. So pathophysiology, a normal aortic valve area is about 3.5 to 4 centimeters square. That's a normal valve area when it's wide open. If you measure the circumference of that area, you'll get 3.5 to 4. Critical aortic stenosis is less than 0.8 centimeters squared. You can see how small that valve area has now gotten. Not very, very big at all. This is important here, these last two. The systolic gradient between the left ventricle and the aorta can exceed 150 millimeters of mercury. Places a large afterload on the ventricle. What is afterload? Overcoming the aortic pressure to get out. Well, now, not only do you have to overcome the aortic pressure in the system, but the valve is very tough. You have to squeeze all that blood through a smaller hole now. Okay, we have to generate a lot of pressure to get all that blood out of that little hole. What happens as the heart has to squeeze harder with every single beat? It gets thicker, hypertrophy is going to happen. So here's your aortic stenosis. Obviously, here's your tricuspid aortic valve, thickening, stenotic leaflets. We get hypertrophy of the left ventricle because the heart is now squeezing to get the blood through a smaller hole rather than when you had a big one. Think about trying to drink through like a boba tea milkshake straw, how fast that stuff comes out versus trying to drink something through like a coffee stirrer straw. You have to generate a lot more pressure to suck that fluid through that little hole than you did through a normal size straw. So we got 5 minutes. We'll take a break in a minute. So here is our Wigger's diagram. I said we'd be coming back to these things mainly in the valve areas, and here we are. So if you look at here, here's your aorta, so your systemic pressure 120 over 90. But because we have aortic stenosis, the left ventricle is going to spend a lot of time in what phase of the cardiac cycle? Because of the increased afterload, what phase are we going to spend a little bit more time in? What do we have to generate? What's the phase where we generate pressure? Isovolumic contraction. We're going to spend more time in isovolumic contraction because we have to generate a ton of pressure. Look how high this left ventricular pressure is, 240. All that extra pressure generated just to maintain, your normal aortic systemic pressure of 120/90 for your normal blood pressure. Okay? Heart has got to generate a ton of pressure to get it out. Now let's look at the phonogram, the sound. We have an ascending, crescendo, decrescendo, systolic murmur. Okay? Crescendo, decrescendo, systolic murmur. The sound will get louder and then it gets softer during systole. That is aortic stenosis. As left ventricle becomes thickened and less compliant, our compliance curve gets altered. Thick hearts don't fill well, compliance gets altered. So the compliance curve gets moved. Because the LV must pump against a fixed gradient, our increased afterload has now jumped up. And finally, the heart got thick, hypertrophied. All that extra muscle can now generate more pressure, so eventually we get increased contractility because we do have extra cardiac muscle now. Is it a good thing? No, but it's what the heart has to do to compensate for the aortic stenosis. The LV has to hypertrophy to get the contractility back, to maintain a stroke volume. Okay? So these are the changes that occur with aortic stenosis. The valves still all close, so every point is still sharp. They all close, nice little sharp boxes. Where are we at? Okay, let's take a break. We'll come back. Come back at 11. Okay, you guys ready? Okay, let's get through these valves. So, we talked about aortic stenosis. It has to generate a ton of pressure to get through that small valve area now. We talked about one of the compensatory mechanisms is to have the left ventricle hypertrophy to get thicker, to improve contractility, to get the blood out. When this happens, the cavity, so like the chamber size itself, still stays normal size. It's just the wall gets thicker. That's all. So because of this, with aortic stenosis, they develop what's called concentric hypertrophy. You're going to see changes with a different type. So concentric hypertrophy is with aortic stenosis. Now, this next part. To maintain a stroke volume, the heart is going to increase our end diastolic volume, which is increasing what property? Preload. Left ventricular end diastolic volume is going to alter your preload. So that tells us that these aortic stenotic patients, they need the preload. They need that left ventricular end diastolic volume to be high, or they won't have enough blood to get the blood out of the heart. So if you give a patient with severe aortic stenosis a diuretic, what's that going to do to that patient's blood volume? Decrease it. What's going to happen to your end diastolic volume now? Decreased it. If you do that enough to a patient with aortic stenosis, you're going to cause heart failure. because there's not enough blood there to prime the pump, essentially, to get the blood moving because you reduced it too much. Be careful about preloads with aortic stenotic patients. They need that preload to get the blood going out of the heart. If you reduce it too much, you're going to knock it out, put them in heart failure. So, what was the heart sound that we learned about that may show up with some patients with aortic stenosis? S4. And what is the S4? Atrial kick. We need a little bit more blood to increase our end diastolic volume. So because of that, now the atria get involved. And they're going to start squeezing a little bit more to provide more of an end diastolic volume. So you get a prominent A wave on your vascular curve as the left ventricle becomes more dependent on the atrial contraction, that atrial kick, to get more blood in the ventricle. Okay, so that's why you get an S4, the atrial kick, to help that last little bit of blood get into the ventricle to improve your preload. So we talked about the symptoms before: chest pain, syncope, heart failure. These are the three main ones that they get. Why do they get it? Angina pectoris. Half of patients with an aortic stenosis will have significant CAD. So when you guys start learning about management, anyone that has a valve problem, if you want to repair it surgically, you have to have them do a cardiac catheterization first to make sure their vessels are okay. Because you're already opening them up anyway. If the valves are bad and the vessels are bad, just repair it all at once. The chest is already open. So you want to make sure that majority of them with AS are going to have CAD anyway. Just check it out. Even without coronary artery disease, they have increased oxygen demands because they have hypertrophy. There's more muscle. More muscle requires more oxygen. Okay, so the oxygen demand goes up. We also get decreased supply of blood due to excessive compression of the vessels. As the heart squeezes, remember, when does the heart itself, the muscle, get perfused? During which phase? Diastole or systole? Diastole is when the cardiac muscle is being perfused, because during systole, the whole heart is squeezed and all those little vessels are squeezed as well. So it's only during diastole is when the cardiac muscle is being perfused. So you have a mismatch. The supply and the demand don't match, you get ischemia. That's why when you start exercising, the demand of oxygen goes up, your breathing goes up, all that stuff goes up. As long as it matches, you're okay. When they don't, you get ischemic changes in pain. You can also get coronary artery obstruction from calcium emboli that can break off of these stenotic valves. Remember, with degenerative aortic stenosis, it's calcification that occurs of those leaflets. But uncommon. The next one, syncope, due to decreased cerebral perfusion, because you have this obstruction, less blood is leaving the heart, therefore less perfusion to the brain, may cause some syncope, may also have some transient atrial arrhythmias with loss of that atrial kick. And when you lose the atrial kick, you lose that little bit of preload, and that can cause less blood leaving the heart, reduced stroke volume, and you pass out. Ventricular arrhythmias are also very common, bless you, okay, which can cause syncope as well. Ventricular tachycardia, ventricular fibrillation are things that can also arise, and they'll cause the patient to pass out. Less blood leaving the heart. The last one is heart failure. Again, progressive increase in left ventricular end diastolic volume can cause elevated pulmonary pressures and pulmonary edema because more blood, or the increased preload, more blood leaving. But also remember, the heart is becoming thicker, more hypertrophic, and leads to heart failure later on. So this is the three cardinal symptoms of aortic stenosis: chest pain, syncope, heart failure. So I have to switch over to the desktop, but we can listen to some sounds now. Okay. So let me see how loud this is first of all. Okay. So just watch it first. I'll replay it, but do you hear that? In between S1, S2, systolic murmur. Peripheral pulses are going to be late and slowed or delayed, weak. Okay. So that's aortic stenosis. Okay. I'm going to start from the beginning so you can hear the normal sounds again. And then this is normal. No, this is abnormal. This is it. They didn't give us the normal sounds.
Sounds like that.
I know. They didn't give us the normal sounds in the beginning. Yeah. The other ones do. Okay. So that's aortic stenosis. This is the one you're going to hear, the most common one, because it's a systolic murmur. It continues the whole way through for the most part. But that is aortic stenosis. Okay. If you download the PDF version of the lecture, the videos aren't included. Well, they don't show up because of the PDF. If you downloaded the PowerPoint has the video built into it, so you can listen to it later. So that's aortic stenosis. Now, we're back to our hypertrophic cardiomyopathy. Okay? They both cause outflow tract problems. One is the aortic valve, and this is called subvalvular. It's below the valve. So if you ever hear these commercials for like Xarelto, Pradaxa, I don't even know, I haven't seen a commercial for that for a while, but they always say, this is not for subvalvular stenosis. It's only for the valve issue itself. HOCM is a subvalvular stenosis. It's below the valve that's causing the obstruction, the stenosis due to the septum going into the left ventricle, causing obstruction. Aortic stenosis is an obstruction with the valve itself. HOCM also has a crescendo, decrescendo, systolic murmur noted on PE. So when you hear that sound, you're going to hear a crescendo, decrescendo murmur. But you don't know, is this aortic stenosis or is this HOCM? Which one is it? So the obstruction of the outflow tract in HOCM is dynamic, with greater obstruction when preload is decreased from decreased intraventricular volume. So when we do the Valsalva maneuver, you have your patient bear down, you put your stethoscope at Erb's point, and you're listening for the intensity of that murmur. Does it get louder or does it get softer with the Valsalva maneuver? So when you have that patient bear down, okay, we're going to decrease venous return, which causes the HOCM murmur to increase. So if you listen to you go to your aortic area and you hear that crescendo, decrescendo murmur, you don't know right now, is this AS or is it HOCM? You're going to get an echo anyway, which will tell you exactly what's going on, but you're not going to have the echo yet. So listen, if the murmur gets louder with Valsalva, it's HOCM. If the murmur decreases with HOCM, it's caused by a valvular stenosis, which is obviously AS. So AS and HOCM sound the same normally. If you hear this aortic stenotic type murmur, go to Erb's, have the patient bear down, and you listen. Does that murmur get louder or softer? If it gets louder, it's HOCM. If it gets softer, it's aortic stenosis. Everyone good on that? When you have lower preload, that IVS is going to bow greater because there's less blood in the left ventricle. That IVS is going to go into the left ventricle more. Okay, do you see how during systole, do you see how much of that ventricle is taken away? Here's the outflow tract. We blocked it. We caused a subvalvular stenosis. This gets louder with Valsalva because we decrease the preload. And if the sound gets softer, it's aortic stenosis because less blood is moving across the valve. Right? With aortic stenosis, there's less blood. We have Valsalva maneuver. We know we're decreasing our preload. Therefore, the ventricular volume is going to decrease. Less blood floating against that aortic valve. So the sound gets softer. Everyone good between AS and HOCM. Very, very important for this class and obviously cardio and PD as well. Okay, that was it on aortic stenosis. The other ones go faster. That was a long one. Next one is aortic regurgitation. So now the valves don't close properly. They stay open during systole. What's going to happen to the blood after the heart squeezes it out? What is the dicrotic notch on when you hear a dicrotic notch, what actually is that sound? And hitting the aortic valve, a closed aortic valve. So we know the blood's going to come back because the aorta has recoil. It's going to squeeze, blood's going to go forward, but some of it does go back, but it hits the aortic valve, causing the dicrotic notch. Here we have aortic regurgitation. The valve doesn't close all the way. So when that blood comes back to the aortic valve, the valve is open, so that blood is going to go back into the left ventricle, causing volume overload. We're going to have an overload of blood on the heart. Aortic stenosis is a pressure problem. Aortic regurgitation is a volume problem. There's too much volume of blood on the heart now because we're filling from the atria, but we're also filling from the aorta at the same time. So we're getting increased amount of blood in the ventricles. So it's a volume overload problem. This is with chronic aortic regurgitation. It takes a long time to develop. Next thing is this acute aortic regurg. In this one, there's no time for these compensatory mechanisms to take place. They can't be activated. So with acute aortic regurg, volume overload on the heart. If the heart can't get the blood out, where is it going to start backing up to? Pulmonary, right? The lungs. Because this is left ventricle, can't leave. If it can't leave the left ventricle, atria, pulmonary vein, lungs. That's why they get shortness of breath, pulmonary edema, and hypotension with acute aortic regurg. It's like an immediate overload on the heart. That valve just flopped over, it doesn't close anymore, and all that blood just comes right back into the heart. So with chronic AR, pounding pulses, there's a lot of volume in this heart now, and when the heart is rejecting the blood, there's going to be more blood leaving the heart as well, so the way that the intensity of your pulses is going to be stronger. Here's your apical impulse, hyperdynamic and displaced laterally again. Yes?
With chronic AR,
Yeah.
is it like the valve goes bad like slowly over time?
Yep.
And then acute, it just fails randomly?
Yep, so think of the aortic valve, you have 3 leaflets. If one of those leaflets decided eventually the tip stopped working, and then it got bigger and bigger, then finally the whole leaflet stopped, that's the chronic one. It starts off slowly. And that regurgitation gets worse and worse and worse over time. 3 murmurs may be heard with aortic regurg. This is a diastolic murmur, so it's going to happen after S2. Usually it can be a high-pitched, early diastolic rumble, or it's really just a diastolic rumble is the biggest thing you're going to hear. A diastolic rumble. You may also hear a third heart sound. What's S3 again? ventricular filling, because you're getting blood hitting from different sides. In acute AR, no peripheral signs because there's nothing, that's a compensatory action. This is too fast. Many cases, the LV impulse is normal. Again, it's not displaced because there's no hypertrophy of that ventricle yet. Hasn't had time to have that happen. Auscultation, diastolic murmur is going to be softer. May have an Austin Flint murmur, which is that diastolic rumble. First heart sound will be soft and sometimes absent because we're flowing back in at the same time the mitral is flowing, and they kind of override each other. These are some causes of regurgitation. If it's a valve problem itself, you have these cusp abnormalities where they don't touch anymore. These are some examples: rheumatic heart disease, congenital issues. With aortic dilation, so if we have our aortic valve, right? So we have our valves. Normally they're touching and everything's okay. Okay? With aortic dilation, the aortic root gets bigger, but the leaflets don't get bigger because of the dilation here. So you get blood going back in. That's what we're talking about here about separation or dilation of the aorta. The aorta itself, the root got bigger, and the valves don't come close to each other anymore, causing a regurgitation. Because the valves don't touch, blood can get through very, very easily. So that's what we're talking about here about aortic dilation. Aortic aneurysm will do it, some inheritable diseases, Marfan syndrome. We'll talk about Marfan when we get to musculoskeletal in Unit 3. But they get aortic valve issues with Marfan. And the last one is inflammation as a cause, and tears with loss of commissural support. So we talked about before how, remember the aortic valve, how's the aortic valve? Is it anchored to anything or it just floats in the space? Which one's anchored? Mitral is anchored. The aortic valve isn't. So if any of those leaflets just break, they tear, they're not going to touch anymore. So an aortic valve leaflet can tear as well. If it's torn, the integrity is gone, it's not going to close properly, causing aortic regurgitation to occur. Okay, so with regurg, large volume load on the left ventricle, because during diastole, blood is filling from the mitral, from the aorta, from the atria, and the runoff from that leaky valve. So during diastole, the heart is getting filled from two spots, not just one. If the regurgitation develops slowly, we get fiber elongation, sarcomeres get longer, and we get increased ventricular volumes. So the volume of blood, the end diastolic volume, is going to be bigger because we're getting filled from both sides. So we get a thicker heart, and in this case, with aortic regurg, it's eccentric hypertrophy. With aortic stenosis, they get a concentric hypertrophy. You will see these words on an echo report. The cardiologist who reads the echo will say, I see concentric hypertrophy or eccentric hypertrophy. It'll be on the report. So aortic stenotic patients get concentric hypertrophy. Aortic regurg gets eccentric hypertrophy. Because the valve doesn't close all the way, there's no true isovolumic period because the heart is going to be filled during diastole as well. Because the valve isn't closed, blood's continuously moving, and we'll see how the pressure volume curves change. Diastolic blood pressure decreases because less blood is leaving into the system. A certain percentage of all the blood leaving the heart comes back into the heart. Your diastolic blood pressure is developed by the pressure in the system during rest. But now less blood is leaving, so the diastolic pressure decreases. And eventually they get elevated stroke volumes, lead to increased systolic pressures because they have an increased end diastolic volume because they're being filled from two spots. Backflow from the aorta and the mitral valve, or the atria filling normally. So this is what's going on with aortic regurgitation. So you can see here the structures don't close all the way, they're fibrotic, so all this area stays open during diastole when it should be all closed. Because of that, we get a dilated and hypertrophied left ventricle. Dilated because of the excess volume of blood that's going to be in that chamber. It's going to get bigger to accommodate all the blood. And it has to get thicker to squeeze all that blood out of the heart. So you get the hypertrophy there as well. Okay, here's our first part of our Wigger's diagram. You can see the biggest change, one from aortic regurg to stenosis. The heart doesn't have to generate a whole lot of pressure above aortic pressure anymore. So we don't have to worry about that. But look at the aortic pressure. What is it now? 120 over 50. Why did the diastolic pressure drop so much with aortic regurg? Where's the blood going, or where is it not going, all of it? It's not all going to the body anymore. Some of it's coming back into the heart. Less blood out in the system, diastolic pressure goes down. So this is going to be called a widened pulse pressure. And what is pulse pressure? Just systolic minus diastolic. The wider that number is, the wider the pulse pressure, indicative of aortic regurg. Okay? Looking at the phonogram, don't worry about the systolic murmur so much. This is this diastolic murmur, this diastolic rumble that's going to happen right after S2. Why does it happen right after S2? Because the aortic valve is supposed to close at S2, but it doesn't close now. So once S2 happens, blood's going to come right back in. So you get a little bit of a diastolic rumble right after S2. Here is our pressure volume. Because the aortic valve doesn't close all the way, we get curves at the points now. We don't get nice sharp corners on the cardiac cycle anymore because the aortic valve can't close. So every time we put aortic closed, it's not really closed because we have regurgitation. Valves don't touch anymore. Also, look at the stroke volume. Look how wide the stroke volume is now. Look how big our preload is. Remember, aortic regurg is a volume problem. So preload is going to be affected. Afterload is fine. The systolic portion is okay. It's the diastolic portion that's the problem. So our stroke volume goes way up because we're filling from two areas. So symptoms of aortic regurg: shortness of breath, pulmonary edema. If it's acute, you go to flash pulmonary edema due to the overload when the ventricle can't compensate. If they have chronic aortic regurgitation, if those compensatory mechanisms fail, they'll start operating on a steeper portion of that diastolic pressure-volume relationship, giving you shortness of breath. Physical exams, hyperdynamic pulses, there's more blood leaving the heart, more blood in the system, or hyperdynamic pulses with each stroke. Murmurs, obviously, third heart sound from filling issues. So let's go to listen to aortic regurgitation.
Personal injury accident happens, it can feel like your whole life is falling apart. Here's what you need to know.
Aortic regurgitation. The classic murmur of aortic regurgitation is a diastolic, decrescendo murmur, usually heard in the third or fourth left intercostal space. This murmur has a high-pitched character. Listen to a patient with typical aortic regurgitation. I will begin with 3 normal beats and then add the murmur.
Okay. Do you guys hear the S1, the clear S1? You hear no sound, that's during systole, and then because the aortic valve is not going to close, so you don't have an S2. There's no snapping. And then is just the blood rushing back into the heart. Yes?
So like the initial, like the stroke volume is large, but then it ends up falling like
Back into the heart.
So like the cardiac output is that
It's going to be affected a little bit.
it's like decreased.
Yep, that's why the diastolic pressure is dropped so much, because there's no volume, not as much volume is leaving, it's coming back into the heart, causes the extra volume on top of the heart because it's getting filled twice. Okay, I'll start over again.
The classic murmur of aortic regurgitation is a diastolic, decrescendo murmur, usually heard in the third or fourth left intercostal space. This murmur has a high-pitched character. Listen to a patient with typical aortic regurgitation. I will begin with 3 normal beats and then add the murmur.
Okay, you hear the difference between that one and aortic stenosis? Big difference. Okay, good. Okay, moving on to mitral stenosis now. Clinical presentation for mitral stenosis: dyspnea, fatigue, and hemoptysis. What's hemoptysis? Coughing up blood. How does a valve issue cause you to cough up blood? We'll find out as we go through it. Occasionally they'll have a fast heart rate. They do get some neurologic signs with mitral stenosis. Maybe get some weakness of the extremities, sudden loss of vision, difficulty with coordination. Lack of blood to the brain will cause these issues. Characteristic murmur: late, low-pitched diastolic rumble. Why is this a diastolic murmur? The mitral is open, right, during diastole, so that's when blood is going to flow across that mitral valve. Only during diastole, because that's when we fill. So mitral valve is only open during diastole. You'll only hear the sound of the murmur during diastole. Okay, auscultation of lungs, they may have some rales as well due to backup of blood, and we'll discuss it as we go. So same thing, mitral stenosis, very, very small orifice right there for the blood to move through the mitral valve. Because the blood is stuck in the atria, the atria are going to have to squeeze a lot more to get the blood through that stenotic valve. When we talked about aortic stenosis, the left ventricle has to push against the aortic stenosis, so you get hypertrophy of the left ventricle. Now we have mitral stenosis. So now we have problems getting the blood from the atria down to the ventricle because you have a smaller hole to get it through. So now the left atrium is going to hypertrophy because it's having to squeeze and kick in a lot more because you don't have, normally it's just a pressure difference going from atria to the ventricle for the blood, and that gets it through. But because now the valve is very, very, very tight, you don't have enough time to get all that blood through the hole in the amount of time. So now the atria have to squeeze to squirt it through more. So you get left atrial hypertrophy. Okay. Left atrial hypertrophy. We may also get some issues with our chordae tendineae, the anchors that hold down that mitral valve. When we get to mitral regurg, we'll talk about the chordae tendineae a lot more. Okay, so those are some things that happen with the mitral. Now, let's look at our pressure, our Wigger's diagram. Look at where the left atrial pressure is now. 25/14. That's very high for right atrial pressures. Or for left atrial pressures, that's high. Okay? Why is it high? Because it's having to generate more pressure to get the blood out of the atria. If you look at all the ventricular stuff, aortic, it's okay. There's no changes there. Pulse pressure is good, 120/80. There's no issues with that. Widened pulse pressure. We just have elevated left atrial pressures. Now, this is a diastolic murmur. That's what it's going to do. Just imagine you're having to squeeze. It's like when you have like a ketchup bottle or a mustard bottle and you're trying to squeeze that out of the tube. The pressure you're having to squeeze is what the atrium is having to do to get the blood out. And when you squeeze it, it's going to make a noise as it squirts through the opening. That's what stenotic valves are. Okay, our pressure volume curve, because the filling of the left ventricle is restricted, we change our preload. Okay, just the preload, and obviously our stroke volume is going to get reduced because less blood is going into the ventricle due to a stenotic mitral valve. So less blood, less stroke volume. Causes for mitral stenosis, here's our rheumatic fever again. Okay, 20 years after acute rheumatic fever is usually as a child, so late 20s, early 30s is when that may start kicking in. Calcific valve is usually to cause mitral regurgitation, but it can also cause mitral stenosis. Congenital, again, when they were born with it, it'll probably present mitral stenosis at some point when they're younger in ages. And any type of collagen vascular disease, again, these are infiltrative diseases. They mess up the tissue of the heart, and there's your lupus. RA is rheumatoid arthritis. You'll learn that a lot more when we get to the MSK stuff. Okay, mitral valve is normally bicuspid. Normal valve area is 5 to 6. And then clinically relevant stenosis occurs less than 1 centimeter squared. So the valve area for mitral is a lot bigger than it is for the aortic valve. We get elevated pulmonary venous pressures and elevated right-sided pressures. Why do they get that? Where's the blood backing up? Well, where is it first? Left atrium is where the blood is backed up. The left ventricle is fine. It just can't fill because of the stenotic mitral valve. The left atrium is backed up. Where does that backup go to? Pulmonary vein, then the lungs, which will then be translated to the right side of the heart. So they get elevated right-sided pressures because remember, the right side of the heart, the afterload is generated by the pulmonary pressures. So the higher the pulmonary pressures, that means the right side of the heart has to squeeze against that pressure, so right-sided pressure starts to rise up. We get dilation and reduced systolic function of the right ventricle. Can be seen with patients with advanced mitral stenosis, where you get back up all the way. So when we talked about heart failure on Wednesday, I said one of the causes for right-sided heart failure was mitral stenosis. And this is why. You don't have left-sided heart failure. The problem is the mitral valve itself, causing the stenosis, the blockage in the flow, and you get backup of pressures and exerts itself on the right side. So that's how mitral stenosis causes right-sided heart failure. So that closed the loop on that one we talked about on Wednesday. So symptoms: shortness of breath, hemoptysis, and orthopnea. When you get these elevated left atrial pressures and that pressure is translated back into the pulmonary system, remember, these are pulmonary capillaries. They're very, very, very fragile vessels. Any increase in pressure can pop those capillaries. When those capillaries pop, the blood drains into the lungs and you cough it out. That gives you your hemoptysis, because those pulmonary capillaries burst due to the high volume, high pressure translated from the mitral stenosis, causing you to have hemoptysis. Same thing with orthopnea. Palpitations. The increased left atrial size, remember it's gotten bigger, hypertrophied. The left atrium doesn't like to be stretched out like that. And when those sarcomeres start to stretch and that tissue starts to stretch and get bigger, that tissue gets irritated. And if that left atrial tissue gets irritated, it's going to send off signals and it'll start depolarizing randomly, causing you to have palpitations because your heart's going to start beating harder because of that left atrial size increasing. It irritates it, causes all these signals, atrial fibrillation, atrial flutter, atrial tachycardia, whatever it is, it's generated from the left atrium. So they get these atrial arrhythmias due to chaotic atrial activity. Neurologic symptoms, okay? We get reduced outflow, less blood is leaving the heart, less actual blood. The ejection fraction can be normal, but what is the actual volume of blood leaving the heart? It's going to be lower because there's less filling due to the mitral stenosis. So you get dilation of the left atrium, and you get this stasis of blood flow. There was a little piece I told you to remember on the anatomy for the heart in the left side. What did I tell you to remember? It's not really functional except for some little things. The left atrial appendage. The left atrial appendage is a little piece that hangs off of the left atrium. It's usually there for like when we're exercising and we need more blood to get through. The left atrial appendage will pop open and assist with atrial kick. But in normal situations, it's pretty much closed, doesn't do anything. When you have atrial problems and the atrium doesn't squeeze very well, blood will get stuck and it'll start to pool in that left atrial appendage. What's going to happen with blood that sits around and doesn't do anything? It's going to clot. Okay? So we get a thrombus, which is a clot, in the left atrium in about 20% of patients. What's going to happen next, do you think, with that clot? It's going to break off. And when things are in the left atrium, where does it go next? And where does it go from there? Left ventricle goes to aorta. And what's the first branch of the aorta? Right? And then it goes to the carotids, right? So where do you think that clot's going to go first? Straight to the brain, causing a stroke. That's why with atrial fibrillation, we're so careful with strokes, because the blood just sits in that atrial appendage, causes clots, and they break out. Yes?
Can people also get pulmonary embolisms from this too?
Nope, it's on the opposite side of the whole circulation. If it's on the right side, then yes, because, okay? So the embolic events, here's your AF. We're so worried about that. Now, here's the last little important part. Left late atrial enlargement can also impinge the left recurrent laryngeal nerve. It's right on top of that atrium. When that atrium gets bigger, it's going to pinch that left recurrent laryngeal nerve, and they get a hoarse voice. It's called Ortner's syndrome. Compression of the left recurrent laryngeal nerve due to left atrial hypertrophy. So some come with a hoarse voice, signs of heart failure. Check the valve, make sure it's okay. Like I said, looking at plans for these patients, all of these patients are going to get an echocardiogram, which will tell you exactly what's going on, the size, the structure, and the function of the heart. Your job is to figure out, okay, they do have an abnormality here. I can kind of figure out, is this a systolic problem or is it a diastolic problem? The echo will confirm those things. So let me go to mitral stenosis.
Near binaural devices uses dual mode stimulation to soothe tinnitus.
That's how you can tell AI, because they don't pronounce things right. Immediately you can tell tinnitus, it's tinnitus. You skip the video, move on, it's fake. Okay, sorry.
Stenosis. This murmur is by far the most difficult murmur to correctly identify. The diastolic murmur is low-pitched and rumbling in character. The low pitch requires the clinician to use the bell of the stethoscope applied lightly to the cardiac apex with the patient in the left lateral position. Listen to a patient with mitral stenosis. I will...
Okay, well, I don't want to do
Bernie
that.
Shannon's Medicare. When
Hang
a
on.
personal injury accident happens, it can feel like you're...
Hang on a second. Okay. What I wanted to say was the bell, the importance of the bell. If you still have the plastic piece on your bell, you don't have a bell, you have a diaphragm. That piece needs to come off. In your stethoscope kit, you have a black O-ring that's going to cover the bell when you pull off the diaphragm. You have exposed metal, that little ring goes back on it, and now that becomes a bell. When you go on your pediatric rotation, put that diaphragm back on, because peds have smaller thoraxes, so you don't want to cover, like, the diaphragm that you normally use for adults can cover like both valve areas on a baby. So using the smaller diaphragm for babies and kids, the bigger diaphragm for adults. However, for cardiology exam, the smaller head needs to be a bell. So that diaphragm needs to come off. Okay, so listen to this mitral stenosis.
When a personal injury accident happens, it can feel like your whole life is falling apart. Here's what you need to know.
Mitral stenosis. This murmur is by far the most difficult murmur to correctly identify. The diastolic murmur is low-pitched and rumbling in character. The low pitch requires the clinician to use the bell of the stethoscope applied lightly to the cardiac apex with the patient in the left lateral position. Listen to a patient with mitral stenosis. I will start with 3 normal beats and then add the murmur.
Okay, do you hear anything really in systole? You hear dun, 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 right? It's diastolic because that's when the ventricles are filling through the mitral valve. That's why you hear it then. Mitral regurg, which we'll do next, is going to happen during diastole because that's when the mitral valve should be closed, during systole, but now it's opened, and you'll hear a systolic murmur for mitral regurg. So that's mitral valve stenosis. It's a diastolic murmur. It sounds a lot different than the aortic one, right? Aortic regurg is also a diastolic murmur. But aortic regurg happens right at the beginning of S2, and you don't really hear in S2 because the aortic valve doesn't close. So in here, we have an S1 and S2, but we have the stenotic diastolic portion. Everyone good on... Everyone okay? We can listen to it more in PD from there. So let me go back. We got mitral regurg and we're done. Okay, MR. Presentation, how quickly the vascular incompetence occurs. Common complaints, dyspnea, easy fatigability, palpitations. Acute MR may present with symptoms of left-sided heart failure. Does that make sense? Left-sided heart failure, if the mitral, so let's think about it. When the heart goes to squeeze, all of it should, well not all of it, but half of it should leave the heart through the aorta because the mitral valve is closed. But the mitral valve is now incompetent. It's leaky. So during systole, some of the blood leaves the aorta, but some of it goes back up into the atria because the mitral valve is incompetent. So if it goes up into the atria, over time, that pressure will build up into the pulmonary system. So they get left-sided heart failure. Everyone follow that. Always follow the same pathways. Know which way goes forward and backwards. Chest pain may be present if they have underlying coronary artery disease. Physical exam with mitral regurg, holosystolic, high-pitched regurgitant murmur. Holosystolic. So here's S1, here's S2. Holosystolic is like this. It's the same sound, the same intensity through the entire systolic cycle. Holosystolic. may radiate to the apex and the axilla. Murmur will often obscure your first and second heart sounds. If MR is severe, they may have a third heart sound present. So because more blood's going to go into the heart every beat. Chronic MR, apical impulse is often hyperdynamic and displaced laterally. So another mitral regurg, volume overload causes changes. In the past, rheumatic heart disease was the most common cause for mitral valve regurgitation, but now it's mitral valve prolapse. Okay, a lot of females, young females will have mitral valve prolapse. Nothing's wrong with it, it's fine. So what happens is there's extra tissue present on the valvular apparatus, and basically what happens is when the mitral valve normally should close, with mitral valve regurgitation, the valve pops up. It prolapses up, and it pulls up, and some blood can leak up that way when the valve pops. It prolapses. It's a popping sound. MR will follow either poor coaptation of the valves, they don't touch each other, or a sudden rupture of the chordae tendineae. So if that chordae tendineae, which anchors the mitral valve, ruptures, that leaflet is just going to be flopping around, causing acute mitral regurgitation. I talked about heart attacks, and if a heart attack happens, and if you damage the wall where the chordae tendineae are attached to, sometimes patients a week later will go into overt heart failure after a heart attack. One of the causes is they ruptured the chordae tendineae, and that valve is just flopping around now, going into overt heart failure. So acute causes, your ruptured chordae tendineae, ruptured or dysfunctional papillary muscles. Remember the chordae tendineae attached to the papillary muscle, which attaches to the wall of the ventricle. Or a perforated leaflet, endocarditis, eats through the valve, causing little holes to form, and you have a leaky valve. Chronic causes, infection, inflammation, degenerative. Again, these are all long-term processes compared to the short stuff. Chronic AR, they do have time for compensatory mechanisms, MR, I'm sorry, but again, volume load is like aortic regurgitation. Left ventricle and left atrium dilate, and they get hypertrophy going. Diastolic filling increases because you get it from two spots. Mitral filling and, you have the sum of the atrium, the blood return, the venous return coming back into the heart, which is one adding blood, and then you have the regurgitant blood that comes back up. So you get two sources of blood coming back into the left atrium and the blood regurgitant from the left ventricle back up. Two sources of blood causing increased blood volumes in the atria. In acute MR, sudden volume load is too fast, there is no compensation occurring, and you get prominent atrial V waves with MR. So here's your MR. You can have the papillary muscle break, the chordae tendineae. Here's your leaky valve. Pressure changes. Here's your prominent V wave. Okay. Here is your holosystolic murmur. Here's S1, here's S2, and there's your systolic murmur. Holosystolic all the way across. Again, the valves don't close all the way, so you don't have a nice, clean pressure volume loop anymore because the mitral valve doesn't close. Similarly to the aortic regurgitation, widened or increased stroke volume, widened circle here, way out here for preload. Preload's way out there because we have volume is increased. I think yep, two more, we're done. Pulmonary edema, rapid rise pulmonary capillary pressure in acute MR, so they get sudden onset of pulmonary edema, shortness of breath, orthopnea, so forth. So this is acute MR. There's no compensatory mechanism in place. The heart hasn't dilated. There's no changes in the hemodynamic shape. So it all backs up immediately to the lungs, flash pulmonary edema. If it's chronic, they're going to develop gradually. But again, if it fails, pulmonary edema, left ventricular failure symptoms because the mitral stenosis or MR backs up. Fatigue, less forward blood going out because half of it, or not, a portion of it is going back up into the atria, similar to aortic regurg. Palpitations due to left atrial enlargement again. So whenever you start hearing left atrium enlargement, think palpitations, atrial arrhythmias. The atrium doesn't like to get enlarged. Sends off a lot of weird signals, a lot of atrial tachycardias. Let's just listen to mitral valve prolapse, MR, and then we'll be done.
More than a hospital, a place where life happens.
We've laughed and cried.
The mitral valve serves to ensure one-way blood flow from the left atrium to the left ventricle of the heart. It opens during diastole systole when the pressures to prevent blood from flowing back to the atrium as the ventricles contract. The mitral valve has two flaps, known as anterior and posterior mitral leaflets, which are supported by fibrils, which attenuate EP. The mitral leaflets bulge into the left atrium every time the ventricles contract. In many people, the reason why this happens is unclear. In others, it is linked to connective tissue disorders such as Ehlers-Danlos or Marfan syndrome. Connective tissue problems are believed to weaken the leaflets, increase leaflet area, and cause elongation of the chordae tendineae. Asymptomatic and does not require treatment. However, it does involve endocardial valve propagation. The billowing leaf elongated cords may also rupture the flow of the blood is significant volume up to the lungs, causing mitral valve prolapse and regurgitation produce characteristic abnormal heart sounds such as clicks and murmurs, which can be heard during auscultation. Diagnosis is
You hear how it sounds the same all the way through? All through S1, S2, all systolic, holosystolic.
Using ultrasound. A leaky valve requires surgical repair or replacement.
Let me go back.
In a typical valve repair surgery, the floppy portion of the valve is removed and they're confirmed by echocardiography. Murmur, prolapse, and regurgitation produce characteristic abnormal heart sounds such as clicks and murmurs, which can be heard during auscultation.
You can't hear what she's talking over the whole thing though. But you get the idea. The heart is squeezing, but the blood is squirting up in the mitral, through the mitral, into the atria, making that holosystolic sound. That's MR. We are done. See you guys next week. Have a great weekend.